Hey everyone, it's Juniper, and I'd like to present to you guys a case study on congenital pulmonary airway malfunction. So what is CPAM, or congenital pulmonary airway malfunction? CPAM is a mass or lesion of abnormal fetal lung tissue of which it particularly receives blood supply from pulmonary circulation. While it's the most common congenital lung disease, it's relatively rare, affecting about 1 in 25,000 pregnancies. This is usually early growth that stops around week 26, and masses may also begin to decrease in size on their own. So continual monitoring is relevant. 10% of cases result in serious problems for the baby and sometimes the mother as well. There's no known genetic correlation besides type 4. I'll be going over the different types of CPAM on the next slide. And neither is any case associated with maternal factors. Usually, CPAM is located in one lobe, which cannot function as normal. So there are 5 different types of CPAM, and they are classified into subtypes according to what is known as the Stalker classification. And really it resides on different origins of the trachea towards the bronchiolar region and the acini. Type 0 is starting at the trachea or the proximal bronchus. This type is very rare, but also it's going to be incompatible with life. If you imagine that you have hyperplasia around this proximal of a region in the lung, it is not going to allow for the baby to breathe upon delivery. We have type 1, which is a bronchial origin a little bit further down. This contributes to most CPAM cases, and there's actually an excellent prognosis. Type 2 originates in the bronchioles. This is the second most frequent, and there are usually small cysts in type 2. This is often associated with renal agenesis, cardiovascular defects, diaphragmatic hernias, skeletal defects, as well as esophageal atresia. Type 3 is also the bronchial origin closer to the alveoli, and usually these will be solid versus cystic. And then we have type 4, which originates in the alveoli. This type is very rare, and there is a genetic predisposition for this, which kind of sets it apart. Type 4 CPAM is also known as pleural pulmonary blastoma type 1. So it's genetically correlated disorder, and it has a high malignant potential for bronchoalveolar carcinoma. Complications of CPAM. The prognosis is generally excellent, at least for cases without high drops, which is caused by a venous outflow obstruction. If there is a hyperplasia or the lung mass is contributing to a mediastinal compression, what this does is it increases central venous pressure, and this decreases vascular return, and it causes the development of the high drops. We also will have, following the CPAM, this will contribute to infection very commonly. It will contribute to increased respiratory effort, so fast breathing, cyanosis. So if you think about that venous outflow obstruction, and pneumothorax as well. There's also increased risk of bronchoalveolar carcinoma. As I discussed, before, there's the pulmonary hypoplasia with subsequent pulmonary hypertension, and pleuropulmonary blastoma, which is that type 4 CPAM. And then finally, like type 0 originating in the trachea, this is incompatible with life. Differential diagnosis, BPS or bronchopulmonary sequestration is the primary differential diagnosis. It's also a fetal lung mass, though it receives blood from systemic circulation as opposed to how CPAM receives pulmonary circulation. Other differential diagnoses include congenital diaphragmatic hernias, bronchogenic cysts, congenital lobar emphysema, and nematoceles. So the way CPAM is diagnosed is it's usually detected first upon routine level 1 anatomy ultrasound. If it is detected here, uh, the um, there will be a referral to the maternal fetal medicine for a level 2 anatomy ultrasound with suspicion of a CPAM versus that BPS. Um, they will assess the CPAM volume ratio, which is a ratio of the lesion volume to the baby's head circumference, which is a reliable indicator of the baby's prognosis. So a CVR greater than 1.6 indicates increased risk of high drops. So essentially, the larger that lesion volume is, the more it's going to contribute to that obstruction in the high drops. And then there's also mirror syndrome, which will be assessed where essentially the mother mirrors the baby's illness. And so the mother, just like that venous pressure, contributes to a high blood pressure, fluid retention, and furthermore, placental swelling. And furthermore, they also might be referred to a pediatric cardiologist. And so a fetal CT or MRI will determine the size and location of the lesion and see how this lung development is affected. Also, fetal echocardiography assesses whether lesions affect the heart structure of the baby and its function. There's various treatment options. It just depends on the size and number of lesions, whether they are solid or cystic, how much the mass is causing a compression on the heart, and then uh, depending on the degree, if the high drops or this mirror syndrome has developed. So first we have steroids such as betamethasone, um, which slows lesion growth and inhibits high drops. Essentially, it depresses inflammation by reducing formation, release, and activity of endogenous chemical mediators of inflammation, binding and mitigating, causing a mitigation of protein synthesis, depressing leukocyte migration, um, and basically this is going to slow the lesion growth. Also, there's thoracentesis, where we'll have a thoracoamniotic shunt or catheter that will be placed to drain the excess fluid that may develop. We have fetal surgery. So there is one surgery called ex utero interpartum treatment, which is done via the cesarean um, while the baby is still connected to the placenta. Um, that's if the mass is going to be large and success is higher while the baby is still in utero. Uh, we also, if there's, they may induce early delivery. If the mirror syndrome is essentially occurring at a significant degree in order to protect the life of the mother, um, and then also upon delivery, um, they're due to complications like breathing issues, underdeveloped lungs, and high blood pressure. Um, Babies with CPAM should ideally be delivered at a location with a NICU and such pediatrical surgical services, so that way they can be immediately treated. Um, in this case, surgical resection is the management of choice, um, and usually if the lesion is occupying basically more than 20% of the hemithorax, there's bilateral or multifocal cysts, pneumothorax, or if there's a family history of that pleuropulmonary blastoma, um, a surgical resection is recommended. There also may be older children with minor symptoms, and a resection is done as well to prevent recurring infections or the potential for malignancy, especially with type 4. So how this will present via ultrasound, lesions can vary in size and appearance and may be solid or cystic. There may be an absence of visible lung tissue. Lung tissue may present as a hyperechoic mass. Uh, there may be cystic lesions. And furthermore, due to hyperplasia, there will be a displacement of the heart. So on to this case study. There was a 30-year-old patient that presented to the clinic with a history of 3 normal vaginal deliveries, a history of gestational diabetes. They had normal genetic screening, the NIPT, normal alpha-fetoprotein, so no increased risk of neural tube defects, as well as normal carrier screening, no findings. The 7-week dating scan also had all normal findings, uh, and we will see the images. So this is the assessment of the abdominal circumference. As you see here, there is this hypoechoic, this is the lung tissue that we see here. This is a coronal view, noting this hyperechoic lung tissue above the level of the diaphragm. This is a video capturing that tissue, and you can also see this heart displacement, essentially, and its function. Here is a transverse sweep capturing this phenomenon as well, showing the lateral displacement of the heart due to the lung mass. Here is the measurement of that lesion, so measuring 4.0 by 2.2 by 3.0 centimeters. This notes vascularization to the mass. Branching vessels are noted to come from the heart. And this is appreciated as well in this 2D image. We have sub-centimeter multicystic lesions that were noted in the mass. So essentially, with increased size of these cysts, there's a higher risk of fetal hydrops. And so these cystic lesions in general are concerning for CPAM. This is just a sweep, also noting vasculature. And we can see the extent of this mass and the displacement as the heart in this video. This is essentially a very limited heart view of the right ventricular outflow tract, and it's limited, which is due to the mass. Yes, and here we can also appreciate the displacement of the heart. And so also the abnormal cardiac axis, right? Normally it's closer to midline, and we see this essentially large region on the right side. On the left side, this is very compressed, and likely both lung sides are at this point not functioning well. the same thing here. And this is where we have the cardiothoracic ratio that is calculated, and we see that it ends up being the CTCR is less than 0.5, so that is an abnormal measurement. So this was the level 1 anatomy, what these images were from. So overall, the findings included a hyperechoic mass in the right lung. We see the heart displaced severely to the left. We noted branching vascularity from the heart that fed the mass. We measured sub-centimeter multicystic lesions within the mass. We observed an abnormal cardiac axis with limited cardiac views, and this was referred then to MFM with suspicion of CPAM and to rule out BPS. So the level 2 anatomy was performed at maternal fetal medicine. The lung mass measured about the same. This confirms the suspicion, including a left cardiac shift due to the compressing lung mass. Fetal echocardiography and MRI were also ordered at pediatric cardiology. So in the MRI, incorrect cardiac access was noted due to the lateral displacement of the heart. They confirmed a diagnosis of CPAM in the lung mass versus BPS, where the differentiating factor is where the blood supply comes from. And similarly, this was also confirmed in fetal echo, though they further diagnosed a small apical muscular ventricular receptacle defect with bidirectional shunting. So there was essentially a hole at the top of the apex in the ventricular septum, and this contributed to the bidirectional flow. There was they were then followed up with maternal fetal medicine for a delivery plan. They scheduled to induce labor at Banner Desert, which is a high-risk facility equipped to deal with babies with abnormalities, including that they have a neonatal intensive care unit, or NICU, as well with pediatric surgeons and cardiologists on site. The patient would also obtain weekly ultrasounds at maternal fetal medicine to monitor the baby for high drops. And the baby was otherwise normal by passing the biophysical profiles, though pediatric surgery was planned following the delivery, of which there is a high success rate. I did not know how things went after this, though hopeful due to, again, there being a high success rate with what was noted on these scans. Overall, through the study, we learned that CPAM is a relatively rare anomaly that develops in the lungs that may lead to a range of complications if untreated, though there are treatment options. And it was great that ultrasound plays a crucial role in the detection of CPAM, and this supports the guidance of ultrasound for the use in potentially life-saving in treatment options that may be indicated. And that is my case study. I hope you guys learned a lot. Thank you.